Hi, this is Heather Sheline. I have chose to focus my PICOT question on a palliative care issue, and just wanted to give you a little bit of background. In today's healthcare, people are living longer and often have many chronic health issues that reduce their quality of life and create a high level of burden for their personal caregivers. Palliative care referrals are very important to reduce patient and family suffering. They can be cost effective in comparison to extensive curative treatments in the final months of life. They focus on the quality of life versus the quantity of life. When a patient switches to palliative care, it's just like a weight is lifted off their shoulders. I've seen it many times back in my history of working in hospice care. It's amazing how when they decide they're done with curative measures and it's okay to just go the comfort route, it's amazing. They can just focus on themselves and their families and comfort care. So that in turn helps reduce stress and manage symptoms of terminal illness. My actual question is, in terminally ill patients, how do early palliative care discussions compare to late palliative care discussions only after all life-extending measures have been exhausted, affect the quality of life in the final 6 months? In research conducted for this, I used databases from the MOG library, CINAHL, Medline, UpToDate, ProQuest, Consumer Health Complete. Key terms that I used in my searches were palliative care, quality of life, palliative care with screening tools, comorbidities, quantity of life versus quality of life, and dignity at the end of life. The first journal that I'm going to talk about here was publicized in 2024 in the Indian Journal of Palliative Care. The article is Impact of an Early Goals of Care Discussion on Patient Satisfaction and Quality of Life Among Seriously Ill Patients Admitted to the Medical Surge Wards, a Quality Improvement Project. The purpose of this study was to determine the effect of integrating a provider-led goals of care discussion for all seriously ill patients and to assess the impact on post-satisfaction surveys. The time frame was 2018 to 2019. The key findings in this research were that patient satisfaction goals improved. Patients felt empowered when given a better outlook on their specific illness. They had found that most people like to know their prognosis. They like their physicians, their healthcare providers to be upfront on those things. It really helps them plan and get things in order. Upon much later follow-up with the bereaved family, they also had less regret and better quality of life. The strengths of the study: the training of the internal medicine physicians to provide the structured goals of care discussion versus having palliative care referrals brought in can be much more timely in some settings. I know in urban areas, studies show that there's usually palliative care teams in larger hospitals, but rural settings, this is very lacking. There's just not much available. Weakness or limitations of the study: short follow-up span with the patients themselves as they were critically ill. My second article was printed in the American Journal of Hospice and Palliative Medicine in 2021. The article is Awareness of Palliative Care, Hospice Care, and Advanced Directives in a Racially and Ethnically Diverse Sample of California Adults. The purpose of the study was to evaluate racial inequalities in the palliative care delivery model and knowledge deficits among patients of different races. The time frame was June 2018 to July 2019. They had sent surveys out to 2,328 individuals. 74.5% of them were non-Hispanic Blacks and Hispanics combined. I think it was 74% was one and 75% was the other group. They had no knowledge of palliative care, while 49% of non-Hispanic whites had limited awareness of palliative care services. That's a huge difference. Weaknesses or limitations to the study: unable to determine if The survey respondents were raised in rural or urban areas, which can impact availability of palliative care services. My third article is Triggers for Early Palliative Care Referral in Patients with Cancer, a review of urgent unplanned admissions and outcomes. The purpose of the study was to evaluate how palliative care referral trigger tools can help facilitate timely referrals to palliative care and reduce suffering. The time frame and sample size, 159 patients over 12 months. Key findings: when 7 different palliative care referral tools were retroactively applied to patients' medical records, the findings were that 91.2% of those patients should have been offered palliative care referrals or hospice care, when actually only 46% were referred to hospice care, when actually 91.2% hit the palliative referral trigger tools when applied to their charts retroactively. Strengths: trigger tools would likely identify patients prior to terminal admissions. Weaknesses or limitations: retrospective is limited to medical record notes, limited psychosocial documentation as well. Next article, Intensive Care Nurses, Perceptions on Barriers Impeding the Provision of End-of-Life Care in the Intensive Care Setting, a Quantitative Analysis. The purpose is to explore areas with high acuity and high mortality rates, such as the ICU and the ER, nurses' barriers to providing palliative care in these areas. The sample size was 175 nurses. Key findings: the nurses verbalized struggles with ethical disagreements among higher-level providers. The nurses felt uncomfortable with the unrealistic hope given when patients and families should be preparing for end of life. This made care difficult and strained, as they felt the patient and the family should have had more information regarding prognosis. The strengths of this study: I thought this was really interesting. The same study was done 15 years prior, and they compared those results to the two, and many of the same barriers exist, and there has been little change, which is unfortunate. Weakness or limitations: the sample size is a little bit small, 175. Next article, Every Dying Patient Should Experience a Peaceful Death, a mixed methods approach to assessing the benefits of palliative care training on nursing practice. The purpose of this is to determine the effects of end-of-life training on nursing care and attitudes. Sample size: 17 nurses with greater than 10 years of working experience. These nurses were pre- and post-tested after receiving intense education regarding end-of-life care. Open conversation sessions and structured lessons were completed. While test scores did not improve greatly, post-discussion groups had great discussions. Nurses were more empowered and comfortable with advocating for patient end-of-life needs. The weaknesses of this study: the lack of diversity among nurses. All were Christian females. Next article, Educational Needs and Attitudes of Clinical Nurses Providing End-of-Life Care to Patients with Terminal Illness. The purpose of this study was to explore any knowledge deficits among acute care nurses regarding end-of-life care. The sample size was 331 nurses who work part-time or more. 87% were female, 13% were male. Key findings: only 39% of nurses had a satisfactory end-of-life knowledge base to begin with. Emergency nurses were less familiar. Strengths: brings light to the importance of continued staff education. Weaknesses or limitations: smaller number of ER nurses in comparison to med-surg nurses, but you'll have that just about anywhere. You just have less working in your ER than on the floor. Synthesis of this literature: end-of-life care depends greatly on the nurse's level of comfort from previous experiences and also how the provider leads the patient-centered plan of care. Demographics and ethnic backgrounds often determine if palliative care is even an option in the area. Effective communication among the healthcare team is vital for timely referrals. Healthcare teams with advanced end-of-life training are better at exploring the patient's wishes and creating an end-of-life care plan. And last, palliative care trigger tools improve patient outcomes. Evidence-based practice recommendation: utilize palliative care trigger tools. Openly communicate with the patient and the family regarding prognosis and all treatment options, including palliative care. Communicate effectively with the entire healthcare team to ensure that you are giving patient-centered care and make sure all members are carrying out the patient's specific goals. Utilize continuing education regarding end-of-life care or palliative care when they are available, and if not available, suggest them to upper management. This is especially important if working in rural areas where palliative care teams are less available. And in conclusion, through review of literature, consistently studies show the need for ongoing end-of-life education and training with medical professionals. It is also clear that open communication between the attending provider and the nurses is necessary for ideal patient outcomes. Early discussions with patients and family are key to exploring their goals for care and filling any gaps in knowledge. This can only occur if staff are comfortable initiating these conversations. Experience and training helps improve this comfort. Palliative care goals are patient-centered, symptom management driven, and are proven to improve quality of life when the end is near. And here's my list of references. Thank you for listening.